So if we could ask Nitya to make a few comments and perhaps integrate into them how Thailand chose to define the substantial risk that Dr. Grant and his colleagues recommended to the WHO to include in their guidelines, because substantial is a qualitative term that sometimes we have trouble determining what exactly that means. But in Thailand, you had to make a decision to define that so that providers would understand who to recommend for PrEP and who not to. So Dr. Nitya, if you could please.
Thank you very much, and I think that I'm very glad that we have a few examples to share for the region, and I think that that's part because of the environment in the country at this moment, that everyone is moving towards doing anything to end the AIDS epidemic together in the next 15 years, let's say. That's the inspirational goal, as Professor Cooper said yesterday, 1990, and it's by 2030. It's inspirational, but it's something necessary for the country, the stakeholders in the country to move together. And so we came to use the modeling in the country to see how test and treat. That means testing 90% of those key populations and test and treat everyone regardless of CD4 will do for HIV epidemics in the country. And I think that we also gradually learn from the number in different cities like San Francisco, New South Wales, that even if we reach that 90, we will still, we would not be a country that would be exceptional, that if we do 90, we do not need PrEP and we will be doing fine. I don't think that any countries or any cities will get into that situation. So we, instead of like waiting to see how test and treat roll out, will be effective for the country. I think that since we will need to invest in establishing models to roll out test and treat, that's the best time for the country to also think about rolling out other HIV prevention interventions or in package for key populations as well. So in 2012, the stakeholders in the countries come together. Stakeholders here means Ministry of Public Health, funders in the country, Global Fund, PEPFAR, USAID, and also community-based organizations come together and plan how Thailand should move forward with establishing models to deliver HIV prevention and care services. And we came up with the idea to move together both the facility-based or conventional way of delivering service to key populations, and also the community-based or even community-led way of delivering the service. And we have learned that in addition to empower both healthcare professionals and then community people or CBO staff in order to be able to talk about treatment as prevention. When we add PrEP as one of the HIV prevention tools, that really boosts up how they feel empowered to talk to the clients, to bring forward those who may not want to hear any more about HIV testing. If it's only testing and then you put me on treatment, if I'm positive, and so what if I'm negative? You are going to tell me to use condom. You're telling me to reduce number of sex partners. That's not working anymore. So having options for people to come forward for testing and know that if they are HIV negative, they have something, we have something to offer to them. And then if you are HIV positive, then we immediately link them to care, really help boost the HIV testing uptake among those we reach, and this is not only in the hospital setting, but greatly improvement that we can see in the community-based setting as well. And I think that's the starting point of when we including PrEP as part of the HIV prevention and care package that we are going to do for the key populations. I think I would just stop here and then we can discuss later in detail.
Okay. Also want to invite people, if they have questions, to please raise their hands and the microphones can come to them. We have why don't we start here?
My name is Xia Jin from Institute Pasteur Shanghai in Shanghai. First question for Dr. Grant. The PrEP results are terrific, and it's certainly using PrEP increase the quality of sex. And that is very important in the United States and Western countries. But I haven't checked the price of condom recently, but presumably it's much, much more cheaper than antiretroviral therapy. And for a country like China, and how do you advocate to the public health decision makers? PrEP is something ought to be introduced into China. And then another question is for Dr. Panapan. And Thailand presumably is not a rich country. And how do you deal with the cost of using PrEP?
Bob?
So there are circumstances in which PrEP is cost-saving because it prevents acquisition of HIV and eliminates the need for lifelong antiretroviral therapy. We estimate that if PrEP is provided to people who have more than an incidence of HIV of more than 3 per 100 person years, we can actually save money with PrEP because you're not having to treat people. And this assumes that PrEP costs and treatment costs will scale together, and that PrEP costs typically run about half of treatment costs. And that's a realistic assumption because PrEP as a regimen is less expensive to buy, and there's less expensive laboratory testing that's required, and it isn't required lifelong. People can start and stop it. So as long as it's used by people who need it, we think it's cost-saving relative to treatment. Now, what we're finding is it's really the budgetary impact rather than the cost-effectiveness situation that's driving decision-making. Adding PrEP programs can add substantial costs. And even if it eventually saves money this year, and people who make budgets are focused on this year, are concerned about the short-term budgetary impact. And the ways to reduce budgetary impact is to buy drug at less expensive costs and prices. The generic price for emtricitabine tenofovir runs about $70 per person per year in much of the world. Now, those are not the prices paid in China, but it does give you a floor from which to negotiate prices that allow the government to roll out programs in a way that's beneficial for public health and also provides the kind of business model that your pharmaceutical partners require.
Thank you. Nitya, about the Thai?
Yes. Yes, Thailand is not a rich country, and I think that puts us in a very good position to really think carefully whether we will just follow any international guidelines or we should have our own guidelines or own practice for the country. And it's for the treatment at any CD4 count, that's beyond the discussion here, that we now have the model showing that it is cost-saving for Thailand to move towards treatment as prevention, treatment at any CD4 count, and that's why we changed the guideline in 2014 based on that modeling. For PrEP, we are in the process of getting all information because we couldn't use any information from other countries, other populations, and put into our model. We don't really know what will be the adherence rate among young MSM or young transgender women, for example, or even among people who inject drugs and other key populations. So we are generating that data. But at the same time, since we know that the generic drug for PrEP is actually, available in Thailand, either through the government pharmaceutical organizations or from the Indian companies. And we also know that we can further drive down the cost if the demand is coming up. And what we have seen at this moment is that we can get like half the price of the price of generic TDF and FTC available in the country when we are talking about this mass purchase for this generic drug for PrEP use. And at the same time, I think with a quite a good, I'm not very sure if I can say good, but with quite a existing system on surveillance that really makes us make the country feel that we are ready. We know what's the size estimation of our key populations here. We know what's the incidence. Let's say but that's Anna's question at the beginning. How do we know that MSM in Thailand is suitable for PrEP? Since we have various incidence data from cohorts in different regions in the country showing that if we only use the eligibility criteria to get into the cohort of having at least one unprotected sex within the past 6 months, then you get the incidence of at least 5 per 100 person year in any big cities in the country. So I think that makes that we have like this raw data just to be ready to put into the cost effectiveness model.
Thank you. Microphone 3 and then microphone 4.
Yingru Lo from WHO. Bob, great presentation. It's wonderful to listen to you. I have a question with regards to the cost and payment for PrEP. So a major concern in Asian settings where we're discussing pilot projects for PrEP is the concern about the cost. So, and the guidelines, like in Thailand at the moment, recommend that PrEP is paid by the client who wishes to take PrEP. So are you providing PrEP for free in San Francisco? That's one question. The other question is, are you aware about literature about PrEP self-paid compared to not self-paid, whether it deters clients to take PrEP if they pay or not pay? And then a question to Nitaya actually is there any demand, or do you know about anecdotes or demand for PrEP outside of the trials and PrEP 30 in Bangkok and other parts of Thailand, outside of Bangkok and Chiang Mai, I would say. Thank you.
So Bob first.
Virtually all PrEP users do not pay anything for their PrEP prescription. It's either paid for by their insurance companies, which includes public insurance or private insurance, or in our community-based center, about a third of our clients receive PrEP at no charge from Gilead Sciences through one of their 3 patient assistance programs. So co-payments are very low in the United States. I think that there is emerging information about how the price of PrEP affects demand, and actually some of the best data would come from Thailand, so I'll let Nitaya tell us. But there was also a survey done in Hong Kong looking at or asking people what their interest in PrEP would be if it was less than 1,000 Hong Kong dollars. And I think it was 60, and this was work done by Johnson Zinsing Wang at the School of Public Health and Primary Care, Faculty of Medicine, Chinese University of Hong Kong. So Dr. Wang found that 62% of men who have sex with men in Hong Kong would be interested in PrEP if the cost could be decreased to 1,000 Hong Kong dollars or less. And demand plummets at higher prices, as you can imagine. I don't remember the exact statistics, but there is emerging data. Of course, this kind of speculative surveys isn't the same as an actual market performance, but I think that as the private sector starts to offer PrEP in Thailand, as Nitaya is describing, and other places, we're going to see more and more how co-payment structure affects demand.
Yeah, so just to add on the cost that people is willing to pay first before moving to the acceptance rate or demand. When we heard about PrEP 30, many people in the country, I mean in Thailand, question whether that's 30 baht a day or $1 a day is actually feasible for younger generations, because we're talking about people who are coming to the Thai Red Cross Anonymous Clinic where most of them are working age, MSM, with high education, with high income. And a professor in Chiang Mai also raised whether we need PrEP 10 for students in Chiang Mai, for example, and we don't know. But recently that we launched the community-based and facility-based PrEP programs in the country, we asked how much would you like to pay if you have to pay for PrEP monthly. And 70% of people said that they are willing to pay if it's less than 1,000 baht a month, which means around $30 a month, which is good to know, because we still don't know if the country 3 years, 5 years from now will say that PrEP will be free for everyone or not, or we will go towards the co-payment system. We still don't know. But 10% of them, this is high-risk MSM, would say that they would not be able to pay at any cost. They would not be able to pay. So that's just information. And in terms of PrEP demand or PrEP acceptance, we know that there is studies a few years ago showing that around 60-70% of Thai MSM, when asked if PrEP will become available, will you be willing to take PrEP? That's the number that we know from the survey when PrEP is not actually available. But at this time, through these demonstration projects, we kind of see the same acceptance rate when we offer all HIV negative MSM and TG clients that we have PrEP available if you would like to take, and this is MSM at risk and TG at risk as defined previously, that they have at least one unprotected sex in the past 6 months. 50% actually accept the initiation of PrEP at that visit of having HIV test results available to them. And I think that if you look at different sites, it really shows that there are factors that will affect acceptance rate for PrEP, and mainly that is provider. So you will see more or higher PrEP acceptance rate among clinics, which is community-based organization clinic, where providers are non-healthcare professional, but more likely community friends or partners. But you may see around only 30% acceptance rate if this is PrEP offered by infectious disease doctors, for example, who really make you feel like you really need to have this certain level of risk before you can get PrEP. So that's different.
So because of the time issue, we're going to ask Jonathan to make a few comments. The last question will be number 4. I know that there are many people who would like to ask questions. Please see the speakers at the end. Jonathan, quick comment?
So I'll keep it very short. Just from the Israel experience a little bit, but I think we make it a little bit too complicated. The medicine here is very simple. It works excellent. It actually, all the bars we usually put, this is very effective. It's incredibly safe. We had concerns about resistance, about behavior. It's all fine. The data are amazing and compelling. It really is a matter of who's going to pay for it. And I think that we were successful, or there was a lot of luck, but I think keeping it simple. If our part as doctors is very simple. The studies were great. They answered all the questions. And it's simply a question of who's going to pay for it. And I think maybe that should be a message we start with, because there are a few things where we have so much good data, and I think that's an important message, which is effective. And I'll keep it at that. And
okay, Charles, okay. So I think we're going to have to close the session, but Jonathan has a few announcements about lunch.
Great. So.